Good evening, everybody. Welcome to this ESG-sponsored webinar about patient safety. Tonight, we're going to talk about managing safe sedation. We use this every day in our daily endoscopy. And we're going to talk what we need to do during and after endoscopic procedures. So we have three speakers today. Me, myself, I'm Prof. Bisschops. I'm head of endoscopy at the University Hospitals in Leuven. And we invited this evening two anesthetists into the lion's cave, so to say. We have Professor Marc van der Velde, who's head of endoscopy at University Center here in Leuven. And we have Professor Wolfgang Heinrichs from the University of Mainz. So we have an interesting evening where we talk about the risk and complications of procedural sedation and also about the impact of respiratory monitoring. And at the end of the webinar, we'll have some interesting interactive cases where Professor Heinrichs will illustrate what actually can happen if something goes wrong and where accurate monitoring can really help us to prevent complications. And without further ado, I would like to introduce Professor van der Velde, who will talk about risk and complications of procedural sedation. Please, Marc, go ahead.
Thank you, Raf, for the kind introduction, and it is my great pleasure to talk to you about risk and complications of procedural sedation and some tips and tricks to avoid them. I'm an anesthetist, as you mentioned, and I have some conflicts of interest to declare, but I don't think they really bear of interest, because what an anesthetist is for is to provide safe environments for patients. And I'm going to discuss this during my presentation, a definition of what is sedation and the risks associated with it. Then I'm going to indeed talk about risks and complications, the prevention and management, and some take-home messages. In Belgium, we have just finished providing or making a guideline for safe patient care during procedural sedation. And this was made by all university departments and the Professional Society of Anaesthesiology. And we based our guidelines on international guidelines and translated them into our own local practice. And we used as a definition of procedural sedation the following one: the administration of anxiolytic, sedative, hypnotic, and analgesic or dissociative medications to attenuate anxiety, pain, unwanted reflexes, and motion during a diagnostic or therapeutic procedure. These agents are administered in order to facilitate amnesia, decrease awareness, improve patient comfort and safety during a diagnostic or therapeutic procedure. So a very broad definition. And very importantly, I don't have to explain that to you, I think we use the ASA guidelines or ASA definition of the depth and levels of sedation. Level 1 is where is minimal sedation, level 4 where it's basically general anesthesia. So 4 levels, and I think Raf will continue on this as well. These are not easily divided. They are a continuum. You can move from one to the other level almost without noticing it, without giving additional medication. It depends on the stimulus the surgical procedure or the diagnostic procedure is providing you. So it's a continuum. And I think that continuum is very important, that we realize that even if we're in level 1, we suddenly can end up in level 3 or level 4 without giving additional drugs, but if we stop our stimulus or if something else might happen. What are the risks and complications of sedation? Of course, we can discuss a lot of these risks, but I'm going to focus on basically 2, and that is really respiratory complications, respiratory arrest, apnea, hypoventilation, and aspiration of gastric content. And I could give you numerous examples from the literature. I found this a very clear picture. It's on gastrointestinal endoscopy. It's 10 years old, so it's not a very recent study. But it's very contemporary because it basically is in healthy patients. So these patients were, the majority were ASA 1 and 2 patients. They were for gastrointestinal procedures. Most of them were basically elective. So you wouldn't expect that many complications. And the use of drugs was propofol, and in some midazolam or some other drugs. And what we noticed was that despite this quite healthy, normal population for routine care, in ASA1 and ASA2 patients, you had respiratory complications in 1.4% of patients, a risk of aspiration of gastric contents in 1 in 1,000, and a cardiac arrest in 4 in 10,000. So in total, you had approximately 4.5% of complications. Of course, many of them not that dramatic. What is known from the literature is that the deeper the levels of sedation, so the deeper you are into that continuum, the higher the risk of complications. And as I said, it may change during the procedure, so you need to be extremely careful. What is also known from literature is that if you use routinely oxygen in quantitative amounts, you might actually induce hypoventilation, and you might see delayed desaturation because the patient has actually stopped breathing because of the high inspiratory oxygen fraction. So it's probably best to reduce the amount of oxygen you give if the patient is ventilating well. Of course, when the patient is starting to desaturate, you might add some oxygen to it, but giving it too much might cause more problems and might do more harm. The second most important complication I would like to focus is the risk of aspiration. I know many use propofol, and propofol is an anesthetic drug, and it impairs the normal reflexes of swallowing. And you might, with even minimal amounts of propofol, 2 micrograms per milliliter target controlled infusion, you might even end up with the complete impairment of your swallowing reflex. And this might result in aspiration problems, as this study has demonstrated. Recently, last year, an international multidisciplinary consensus statement on fasting before procedural sedation in adults and children was published in Anesthesia. And basically what this guideline or recommendation says is that if you have elective procedures, clear liquids are allowed. And that is actually also what anesthetists are saying for many years. You can use clear liquids for a prolonged period of time, up until 1 hour before the intervention, as long as if these liquids are actually clear. And this is no milk, this is no pulp. So it's basically juices or water, or in my book, sports drinks. That's actually the best drink you can give your patient if they want to keep drinking something. It improves their status. They find benefit of that, and also children will be more compliant with the procedure. However, I don't think a patient should get food, although this guideline would say that you could give some food to up until 4 hours before a procedure, or 6 hours when it's a high risk procedure of aspiration. I don't see the need to do that. Why should a patient coming in for a diagnostic procedure get some food in the morning, while, especially for gastrointestinal endoscopy, they need to be sober for diagnostic reasons as well? So, a few words on prevention and management of these complications. I think it is very important to select your patients in the correct way. ASA 3 and 4 patients have a higher risk of complications. Patients with a difficult airway, a difficult malampathic class, and I haven't shown you the Malampathy classification in this presentation, but where there is a difficulty of the airway, should also be considered high risk. And in these instances, ASA 3 and 4, high class Malampathy, the anesthetist should be involved before sedation is being carried out. I would also advise to avoid the combination of drugs. Monotherapy is usually safer than a combination of various drugs like benzodiazepines with opioids combined. I would also avoid potent drugs and consider propofol, remifentanil as potent drugs. These are drugs that can cause in a snap second respiratory arrest if you're not careful. So these drugs are very potent anesthetics that suddenly, because of a sudden change in the situation where you're giving it, might cause a significant respiratory arrest. I think, and Raf will come to that in a moment, you need to use adequate monitoring. And adequate monitoring is not only saturation monitoring and ECG. I think it also needs to monitor respiration, meaning end-tidal CO2, for instance. Avoid the routine use of oxygen. I would give it whenever there is desaturation, but I would not immediately start it when you have a normally breathing patient in normal medical conditions. I would also encourage you to use, to have somebody monitoring sedation, a person that is not doing anything else. So at the exclusion of other tasks, a nurse that is helping you to do the endoscopic procedure should not be doing the sedation at the same time. That is not a good idea. And of course, you should monitor, but also register all your sedation efforts and also the events that might occur just for medical legal reasons, I think. Everybody involved in sedation during gastrointestinal procedures should have CPR skills and should be able to manage the airway, at least the basic skills for airway management. So, some take-home messages. I would say that despite the fact that many of us consider sedation as a safe procedure, it does carry little risks. They are minimal, they are not high in incidence, but you have a 1%, 1 and 5% incidence of potentially very risky complications. I would avoid potent drugs and I would avoid combination therapy. Identify the high-risk patients based on the Malampathy and ASA classification and have dedicated sedationists, but always under governance and control of the anesthetic department.
Thank you very much, Marc, for this excellent presentations and pointing out the potential hazards of sedation. So people are invited to use the Q&A, and we already have some questions for you, Marc. One of Dr. Karima Tir, who asks, if you are alone with a patient without the anesthetist, what would be the safest to use, midazolam or ketamine?
A very good question. In general, ketamine is a safe drug in terms of respiratory depression. Yeah, if you use it in the correct dose, intravenously 1 milligram per kilogram, it's probably a very safe drug in terms of respiratory arrest. However, it has other side effects. It may cause serious psychotic reactions. It also might cause tachycardia and hypertension, depending on the underlying disease of the patient. So it's not a drug that is devoid of complications, but in terms of respiratory arrest and respiratory complications, it's certainly a safe drug to use. On the other hand, if you use correct doses of midazolam, I think that would probably be the safest option.
Okay, another very practical question that I also wanted to ask comes from Dr. Tufik from the UK, whether you routinely use 4 liters of oxygen via nasal cannula for patients that undergo gastroscopy. So should they, you mentioned that pre-oxygenation might actually not be such a good idea to do. What do you think?
Well, again, in a majority of patients, I don't think that's going to be an issue. I think it's going to be an issue in that patient that's balancing borderline, an elderly patient, perhaps some respiratory problems already. You give a slightly higher dose of your sedative drugs, and then suddenly you add the hyperoxia, and the respiratory drive of that patient is decreased. And as a result, you might end up in a sort of spiral going down, hypoventilation, and then after several minutes, desaturation. Again, I don't think it's going to be a problem if you're an experienced endoscopist doing your endoscopy within a limited time frame, but especially when you're working with people that are not experienced, this might be problematic, I think.
Okay, so that answered the question of 3 people. So this was a question coming back quite often. And then one final before we move to the next presentation, maybe is that if you use propofol, and we come back to the propofol issue, I think later in the discussion again, do you always need to intubate?
No, absolutely not. As you know, in our department, Raf, we don't do that. We use propofol as anesthetists, and we do not always intubate patients. Of course, there are certain situations where we will intubate, prolonged procedures, for instance, but not for routine care. But of course, you need some skills, and you need to be able to identify the patient when it goes wrong. And I think here the dedicated sedationist, in my book, that would be an anesthetist, but it may vary from country to country. A dedicated person to the sedation is required when you're using propofol.
Yeah. So maybe to add on to that, what would be the situation? You already mentioned prolonged procedures. If they're therapeutic, I assume if you have a long ESD, you would do intubation. Any patient-related risk factors where you would definitely do an intubation for gastroscopy and not do a propofol sedation?
Yeah, patients with a very high risk of aspiration, diabetics or reflux, or that patients in emergency situations that are bleeding or that are not that have eaten, and for some reason you need to proceed with your endoscopic procedure. I would always intubate the patient. A difficult gastroscopy because you need to do multiple biopsies or something like that, I would probably also do an intubation. So that are the situations, yeah.
Okay, so we come back to some more questions later on. So people keep on using the Q&A, so we'll take them also after my talk and at the end of this webinar. So we can move on, I think.
Yeah, Raf, and it gives me great pleasure to introduce you as the chairman of our session, but also the lead endoscopist in our department in Leuven. And you are going to talk to us on the impact respiratory monitoring might have in sedated patients in current practice. We look forward to your presentation, Raf.
So thank you very much, Marc. So it's a pleasure to give this presentation, which is actually a real life experience where Marc was also involved. We know now that procedural sedation and analgesia is an important patient-related quality issue because we need to sedate our patients properly to ensure a better patient's experience. So it should be enough. But obviously, as you heard in the previous talk, it holds a potential risk for the patient, so it should also be safe. The question I want to address in this talk is about capnography, whether it can actually render the procedure as such with sedation safer, because I was very skeptical about this issue. If we looked in the guidelines when we discussed this in a department, you could actually bump into this contradiction between the anesthetist guideline that basically say you should use it on all patients when you do procedural sedation, and then our own ESGE guidelines from 2010, where they say, well, there's not so much clinical impact, so therefore it's not recommended as standard. And this changed 5 years later to suggest to use capnography during non-anesthetist administered propofol sedation, specifically in high-risk patients where you intend to have deep sedation and long procedures. So we have on the one hand, the anesthetist saying use it in all patients with a strong recommendation, and then ESGE saying only use it in high-risk patients with a weak recommendation. So how do we deal with that? Well, one of the things I think is that there's a bit of a misconception in the term conscious sedation, because it's a contradiction between sedation, because it actually reduces your consciousness as such. And sometimes it's hard to predict the level where you end up. So you may very well want to start at a level 2 or level 3, but before you know it, you can end up at level 4, which is general anesthesia. And it's sometimes hard to predict this in the individual patient, despite a lot of experience. So for the development of a hospital-wide sedation protocol for capnography was proposed by the anesthetist in our department. And as endoscopists, like maybe many listening to this webinar, we were quite skeptical about the costs related to the introduction of this and also the clinical significance, because at least our feeling in the endoscopy room was that there was not so much happening. We didn't have any casualties or any major events happening. And if we looked at the literature, it's not always so clear to answer this. So this is this study from Denmark, looking at about two times 270 patients with or without capnography. You can see there's absolute number in reductions of hypoxia, but this was statistically not significant. And they concluded that due to the limited clinical benefit and additional costs, that's probably not worthwhile the effort to introduce this when propofol sedation is used by the endoscopists. However, the study is most likely also a little bit underpowered looking at these numbers, because if you look at rare events, well, obviously you need higher numbers to show a significant difference. And therefore, we conducted a pilot study here where we did a before and after quality improvement evaluation, where the first group would have standard of care monitoring with oxygen saturation, blood pressure, and pulse. And the second group, after training and implementation of capnography, we did the monitoring also with the capnography. We only included patients that would undergo conscious sedation with midazolam, either with or without pethidine in the absence of an anesthetist. So no propofol, because by law we are obliged to have an anesthetist in the room for that. So we needed 666 patients to show a 20% reduction in the primary endpoint, which was defined as the total incidence of mild oxygen desaturation, severe oxygen desaturation, bradycardia, and tachycardia. So taking all these complications together. And we would look for the relation with the type of procedure, the ASA class of the patient, and whether the complication happened during the endoscopy or in the recovery room. So this is the procedural distribution. So as you can see, we included a total of 2,136 procedures, about 1,000 in each arm. And you can see that the distribution is mainly towards colonoscopy and gastroscopies, followed by bronchoscopy. And it's quite similar between the capnography group and the baseline. Also, the ASA class distribution is quite comparable between the two groups, maybe a little bit more ASA 2 in the capnography group. And then if you look here at the primary endpoint, so the adverse events, you can see that the incidence of that decreased by 56% after the introduction of capnography, what you can see here. So the target was actually set to reduce this from 11.4 to 9.17, but it was reduced to 5.08, so relative risk of 0.43, which was highly statistically significant. You can see the majority of these were oxygen desaturations, but in total, 100 patients, or 9.2%, receiving standard of care, and 54 patients in the capnography experienced at least one adverse event. So the major adverse events were obviously, and also good for the patients, very rare. Looking at the intervention incidence, also this was lower in the capnography group, with 68 patients receiving standard of care requiring an additional intervention, and 41 in the capnography group, and the majority of that was oxygen administration or stimuli. If we look at the relation to the procedure, actually it can happen during any procedure, as you can see here. So it's not only during colonoscopy where you might administer more than during gastroscopy, and it can actually happen during every procedure when you do give sedation. You can see that for every procedure, the event probability was reduced significantly. And what was also important to note is that the need for escalation of care, which are displayed here at the top of this graph, is actually not necessary in the arm where capnography was used, and that was quite interesting. So if we look at the relation to the ASA class, one might expect that most of the serious adverse events might happen in the ASA level 3, but this is actually not the case. You can have this just as well in ASA level 1 patients or level 2 patients, and there was a reduction of these adverse events in both these groups, which was statistically significant, as was the relative risk for intervention with capnography for ASA level 2 and ASA level 3. So this is really an important finding for me, which was quite surprising. So I wonder where this happened, because I did not have the impression this was going on in the endoscopy room. And actually that impression was quite right, because when we looked at the data, we could see that mainly in the recovery, we had more serious adverse events after administration of midazolam, either with or without pethidine, in comparison to when the patient was also monitored with capnography in the recovery room. So indeed, the risk reduction was highly statistically significant in the recovery, as was the risk for intervention with capnography. And then one of the questions we also wanted to address is whether this is all cost effective. And we use here, obviously, Belgian data, because the study was done in our center. And we could see at least that we would certainly not lose money over this, but we may actually have a slight gain by introducing capnography of 55 euros per procedure, because obviously the escalation of care with sometimes CPR, transfer to ICU, or even mortality can be very expensive. So in conclusions, sedation is an important part of the endoscopic procedure with the possible life-threatening complications that are here to that. Capnography significantly reduces the risk of sedation-related respiratory adverse events and the need for escalation of care, and this is independent of the procedure and the ASA risk level. Our real-life data concur with findings in RCTs and substantiate, I think, the use of capnography during procedural sedation, especially after the procedure, during recovery, and after administration of sedative drugs with a longer time of action, like midazolam and pethidine, in contrast to propofol. So,
thank you, Raf, for an excellent presentation, and also a very important and excellent study that you performed. I think we have a few questions already in the Q&A, and one is is your default position monitoring now oximetry and capnography, so saturation and capnography? Would that be your advice in these patients now?
Yes, as I said, I was actually very skeptical towards this. And you can see that the paper was just published, so we have now submitted this to the hospital administration. Actually, the plan is to go for standard monitoring with capnography and oximetry, yes. Yeah.
Thank you. And then a question is on the practicalities. How much midazolam and fentanyl are you using for sedation, or pethidine are you using for sedation currently? What is your routine?
Yeah, it's a very good question. I think a lot has changed over the years, Marc, especially after discussing with the anesthetist how to assess the risk of the patient, what you pointed out in the first talk. So, well, obviously there is no standard dose. I mean, you cannot give or administer sedation, you know, from behind your desk in the corner behind the endoscopy room and say just give 550, 5 midazolam and 50 pethidine. That's not done anymore. So we do the assessment of the patients, and then it depends a little bit. If I have a 30-year-old healthy male of 80 kilograms, I would, and he comes for a colonoscopy, the standard dose there would be 5 milligrams of midazolam and 50 milligrams of pethidine. Anesthetists find this already sometimes very high, but I think this is what we find very safe. Obviously, if you have an 80-year-old lady of 40 kilograms with some comorbidity, we very often start off with giving 1 milligram of midazolam and 25 milligram of pethidine, or just give the pethidine and see how that makes her tolerate the procedure. So actually, this risk assessment helped us to tailor this. And also, since we have an IV line, which is obviously obligatory nowadays, you can always titrate the sedation. So sometimes when I'm in doubt, I can start with a low dose, give 2 milligrams of midazolam. And then if this is insufficient, you can just easily titrate this and give 1 milligram or 2 milligrams extra, depending on the level of the sedation. I don't know if that makes sense to you, Marc.
No, absolutely, absolutely, and thank you for responding. These are for the moment the questions that have been asked, so I give the word back to you.
Yeah, I see there's one important question for you, Marc, before we move on to.
Okay.
Obviously it comes from the Nordics, from Björn Ferke. And what do you think of nurse-administered propofol sedation performed by well-trained nurses?
Yeah, well, it all depends, I think, on your medical legal situation. I think a nurse trained sedation service is safe if these nurses are trained properly. Yeah. So if you have a clear, well delineated program of training, and it's more than just 1 hour of an electronic training, it's really a program, and they have to repeat it on regular occasions. As long as this training is done by experts in the field of sedation and anesthesia, by anesthetists, I think a nurse-led service can certainly be a safe option. The most important thing is that the person doing the sedation is only doing the sedation. That is the most important thing. If that person is doing 17 other tasks, that's not safe. So that's one aspect. But it depends on the country where you're working. In our country, this is not allowed. There is a medical legal barrier. So we can't organize that. But if you're really in a country where that is allowed, as long as that person is well trained and only doing that, then I think it's a safe option.
I think there's a lot of publications on that. That is actually a very safe way to go forward. And as you say, I mean, there are very good examples where people are trained for that. So we will come back to some other questions. So we'll try to collide them for the end of this webinar. While Professor Heinrichs is getting ready for his live demonstration, I want to give an introduction, because we're going to have an interesting virtual simulation session on what can actually go wrong or well. So Professor Wolfgang Heinrichs is a professor of anesthesiology, and he also is director of a private training center. So he has a special interest in physiological and pharmacological models, and he's been conducting trainings in procedural sedation since 2003. So it's a pleasure for us to have you here and to illustrate to us what actually can go wrong and how monitoring can help. So please, Wolfgang, go ahead.
Thank you very much for this kind introduction, and thank you very much for the 2 excellent presentations we have already heard. And I think I can easily connect to the contents of these presentations. What I'm going to show to you is a method of training the safety of sedation. So what we are doing here, we have a full-scale simulator. This full-scale simulator is driven by some physiological and pharmacological models. So we will be able to apply the drugs like in real life. We will get reactions very similar to real life. And I'm going to demonstrate sedation for colonoscopy using midazolam. And maybe I have to add some fentanyl during the case, and we will see what happens. Actually, my patient, my simulated patient is 65 years old. She's a lady, and I can talk to her. Let's call her Mary. Hello, Mary. How are you doing today?
Oh, I'm quite nervous.
Yes, you are nervous. So I will give you a very nice sedation during the case. And I think you will not feel very much from the procedure. We will wait until you sleep nicely, and then we will do the procedure. And if something goes wrong with you, or if you have a bad feeling, you will just tell me or try to tell me, and then I will help you. I will always be with you during the case. Okay, so
Okay.
I've already instrumented her to the standard monitoring that we use. You see here an EKG You see the heart rate. We have a pulse oximeter. You see a saturation of 94 during breathing room air, and we have a normal blood pressure of 130/70. So I think we have very stable conditions. Because she demonstrates a little reduced room air saturation, I would prefer to administer oxygen. So I will now put this nose oxygen administration here, and we will open this to 2 liters per minute of oxygen. I have to take away your glasses during the procedure, okay? You will get it back after the procedure. And then immediately, because midazolam is a drug which takes some time until it works, I will now immediately start the sedation with a 65-year-old lady. I selected now 3 milligrams of midazolam, which I've injected now, and now we have to wait a little bit. During the procedure, I will be here, I will be taking care of her. I can even clinically monitor the ventilation or the respiration, let's say, because the thorax is moving. So if you look very closely, you might see this. And we have one additional toy here at Archive. This is a BIS simulation. So I'm not recommending that you do EEG monitoring as well for now, but I have a BIS monitor here so that I can demonstrate the sedation by 2 ways. First, she will close the eyes from the pharmacological model, and I will tell you because it may be the case that you cannot see it very clearly. And I have also the BIS value here, and I will give you from time to time, I will give you the BIS values that we reach with our sedation. Still, she is fairly awake, and the BIS value is something 94, now decreasing. She's about to close her eyes, so she shows me that she gets a little bit tired. I think everybody who works with midazolam has a feeling of the time that is used for this. By the oxygen administration, our saturation now is perfect, 100, and she is breathing spontaneously. Now she is closing the eyes. The BIS value is certainly dropping, and we will see lower values. And now it is time for the gastroenterologist to start the procedure. Let's assume we do a colonoscopy. We are not demonstrating for this the real colonoscopy. This can be done, but this is not the topic. And let's assume I have some problems in getting through the sigmoid curves, and she's murmuring now, and she's telling me, "Oh, I'm not happy with the situation." You hear this. So what can I do? I can inject more midazolam, so I can give her another, let's say, 1 milligram of midazolam. Or alternatively, we have heard this, I could add pethidine. Personally, I have to say, I do not like the pethidine too much, so I'm very much used to fentanyl. So I'm now going to inject 50 micrograms of fentanyl in addition to my sedation. Still, I can see she is breathing perfectly, the saturation is perfect, and the BIS value is now down to the 70s. For those of you who are not familiar with this type of EEG monitoring of the depth of sedation, I can tell you that BIS values above 90, let's say 85 to 100, means normal responsive patient. BIS values between, let's say, 60 and 85 are different degrees of sedation. BIS values below 60 then represent a range where we talk about anesthesia or very deep sedation. And if we go below 40, this will clearly be a field of very deep anesthesia sedation, which definitely we do not want to reach right now. The BIS value now dropped a little bit more, so I added midazolam, I added a little bit of this fentanyl, and the BIS value is now down to the 60s. That means it happened that by adding these drugs, we got a sudden addition of sedation. So that means from level 2, where we maybe started, we are now very smoothly in level 4. And now I can also see, because I hear my pulse oximeter, and I can see the saturation is slowly dropping. So I can now try to detect what's going on here. If I put, for example, my hands here, I don't feel much spontaneous respiration. I was a little bit distracted maybe with these nice pictures of the colonoscopy I could observe. So maybe I was a little bit distracted. I tried to explain to you the BIS. So this is a typical situation where your attention is not fully at the patient. And now you see we get an alarm from the pulse oximeter, 88, rapidly decreasing. So now I need to do an intervention. We have a respiratory compromise. We have some kind of respiratory depression. Of course, we are always prepared to do so. So it is just one little step to add the mask, to open the airway and see if she's breathing again, but I don't see any movement of the thorax. So in this case, this would be a kind of worst case respiratory compromise. I now start ventilating a bag mask ventilation. Saturation right now is 83. The BIS value is 50. That means, yes, we are in very deep sedation, let's say even in a kind of anesthesia range. There are a lot of alarms now sounding. I stop these alarms and I do now the intervention here. And what you can see is that although you can trust me, I'm perfect in this intervention and the thorax is moving perfectly, the saturation dropped even further after I started my intervention. And only now I get enough oxygen back into the lungs and the saturation comes up. I'm now back at 90 and rapidly increasing to 100. So actually no very severe complication, but imagine the alarm of the pulse oximeter sounded at 90 very early, and I even recognized a few seconds before. Nevertheless, the intervention resulted in a continuous decreasing of saturation, and only after a while I could be back up. This means I had a period of several minutes where the saturation was below 80, and this would be clearly regarded by all of us as a severe and, let's say, potentially dangerous complication. Okay, I see now she starts breathing again. So this was actually a very short scene, and she starts breathing again. So far, so good. Now we do a very interesting experiment, which we can do only in simulation. We will wake her up. We will put a reset signal to all the computers. And we will repeat exactly the same lady with the same drugs, with the same timing. But this time we will also add capnography to our monitoring, to come back to the main topic of this webinar. So Manuela, if you can switch on, I now ask my technician to switch on the capnography. I have I've prepared here the different sensor that we use if we want to add capnography. So we are not only applying oxygen with this system, but we are also sampling the exhaled air of the patient. And we will see fairly soon that we get a signal from this sampling and the CO2 that we sample here. I will show you this in a second. It's a little bit tricky to simulate real pulse oximetry and real CO2, but we have these facilities in order to show very realistic during such trainings how it works if we use capnography as well. Okay, now can we please switch to the second camera? Okay, now you see the screen of our capnometer. You see on the upper curve, you see the exhaled CO2. On the lower curve, you see the waveform of the pulse oximeter. You see an end tidal CO2 of 50. Obviously, our lady is a little bit breathing slowly, and you see a saturation of 98. And now I'm again administering the 3 milligrams of midazolam. And this time we will be able to observe the sedation not only with our clinical signs, but also with the capnography. And let's observe which differences result from this. Again, it will take a few minutes until midazolam works, but we can speed this process a little bit up in order not to overextend our time slot.
Yeah, I feel a bit dizzy in there.
Now you feel dizzy again. Okay, and now she starts closing the eyes again, and let's again assume we start with the colonoscopy. Let's again assume she's not happy with the situation, and I will add again another milligram of midazolam and 50 micrograms, a very low dose, 50 micrograms of fentanyl. And let's see what happens during the procedure. And now you can observe very closely and much better than by clinical monitoring that the spontaneous respiratory rate is right now 14. You see the little 14 below the 39 of the CO2. And now I've added the fentanyl. And of course, also fentanyl has an onset time of, let's say, 1 to 2 minutes. And what we clearly will see again, the BIS value is down to the 70s again. And we will see now that the respiratory rate will drop. You see from a start point of 14, now 12. It's okay. It's a normal effect of opioids, of course, but if we go to a respiratory compromise, which looks like happens now, you see now the CO2 curve is now flat, and after something like 15 or 20 seconds, we will get an alarm. And what I want to ask you now, please concentrate on the saturation. Now you see the patient is no longer breathing. We don't have any CO2 signal right now. And we will see now a respiratory alarm. You can set this alarm window to 15 seconds or to 20 seconds or to 30 seconds. It depends on how you would like to handle this. And now you see a very clear alarm. The red line tells us respiratory alarm, no breathing. Please observe that the saturation is still 98. And now I can again try to open the airway, or I can start again back mask ventilation, which I do now, because I've now seen we have a respiratory compromise. I will now start back mask ventilation. Saturation is 99. The BIS value is 45. So you can trust us that we are in deep sedation here right now with this old lady. She's obviously not very much used to these type of drugs. She reacts very sensitive to these anesthetic drugs. And I can do back mask ventilation. I get immediately a CO2 curve back on the monitor, and the saturation never ever drops. That means this time we had again a respiratory compromise. Yes, we had again the same complication, and we had again to treat the complication, because capnography will not prevent us from treating such a complication, but capnography prevents us from detecting it too late. So this is the big advantage of capnography. No saturation depression. And now I could continue. I could stop the sedation. I could wait until the patient is a little bit more awake. I can observe the CO2 curve, and then my colonoscopy will continue, and everything will be right after the show. To summarize, what you have seen, 2 times the same sedation simulated, but exactly the same time course of this simulation. First simulation, no capnography. Reaction of the physician or the personnel or the sedationist, whoever is responsible for the patient, when the pulse oximeter alarms. Second time, intervention immediately when a respiratory compromise is detected by capnography. In the first case, a longer period of desaturation following this alarm, although the resuscitation was done correctly. Second time, never any desaturation, so our patient was never in severe danger from any hypoxemia. With this, I want to close, and I give back to Ralph. And of course, I'm also happy to answer any type of questions. Thank you.
Thank you very much, Wolfgang, for this excellent demonstration. I think this is a great tool for people to get acquainted with monitoring and which parameters to get acquainted with. And training for fellows is actually, I think, I can imagine it's excellent on a model like this. So congratulations on that. So actually I have some interesting questions from the audience, pharmacological questions, but this definitely has to go to the anesthetist in this webinar. So there were quite some questions about the order of administration of pethidine and midazolam. Is this important, or fentanyl and midazolam? Should it be the opioid first, followed by midazolam? In the UK to do it like that, or doesn't really matter how you do it? So Marc first, and then Wolfgang.
Well, classically, indeed, for an anesthetic, we will give the opioid first to have an analgesic, a little bit of a sedative, and then we will give our anesthetic, our hypnotic agent, whether it's midazolam or propofol. However, in sedation, the interaction and is the same. Whether you give one or the other first, you will get that interaction, and they make each other more potent. So combination drugs make it all a little bit more unpredictable, and there is an interaction, and it depends on the patient. You have to remember that both for benzodiazepines, but also for opioids and for any other sedative drug, the individual variability in terms also genetically, reactions to these drugs is different. And if you mix up drugs, you might end up in certain patients that are extremely sensitive to both, having serious problems, while others are not sensitive to any of these drugs and might have not a problem at all, even if you give very high doses. But I don't think the order is that important, although classically, routinely, indeed, we give the painkiller first and then the hypnotic drug in an anesthetic procedure.
Yeah, it was also suggested by Dr. Kaskas to really titrate very well with 0.5 milligrams and milligrams. So I think that's sensible. So Wolfgang, one question for you that also came up from the audience. You mentioned also your preference for fentanyl over pethidine. I mean, it depends a little bit on the centers apparently where you work. Are there any pharmacological reasons why you prefer fentanyl over pethidine?
Sure. The fentanyl is much faster, much more potent as an analgesic.
Mm-hmm.
But of course, yes, we know it may be also more dangerous in terms of causing these type of complications. Coming back to the fact, we started with midazolam. So midazolam is, let's say, a fairly slow drug compared, for example, to propofol or also to opioids. And with this, I think it is a practical experience that many people start these type of sedations with midazolam. Then they run into problems because the midazolam might not be enough for the individual patient. And then they have to add an opioid. And in this case, I prefer a fast opioid like fentanyl in an equipotent dose to, let's say, 50 milligrams of pethidine. I think 50 mics of fentanyl is almost compatible to 50 milligrams of pethidine. And then I prefer a fast drug because the midazolam is a fairly slow drug compared to midazolam. If we would use pethidine, we have two long-lasting drugs. So pethidine has a half-life of something like 1 hour. And also midazolam has long-lasting effects after the sedation. Mm-hmm. And this resulted in many studies that have been published in the 70s and 80s, where the most frequent respiratory compromises were found not only during the procedure itself, but in the recovery room after. And we have to accept that in most of the GE departments, the recovery room has even a lower level of supervise and control by nurses than during the procedure. So the combination of these two sorry?
It's also the stimulation of the procedure itself that may keep the patient awake.
Certainly, you're absolutely right. Certainly this also. So in this case, I prefer a short-acting opioid with a longer-acting drug. If you combine, let's say, an opioid with propofol, then you have the short-acting propofol, which we all know, and you can use a longer-acting drug like pethidine or pyritramid, which we use very nicely in Germany, but this is a little bit special. Pethidine is fine. Any other opioid is also fine.
Okay.
Ideally, I fully agree. First the opioid, wait for the opioid effect, and then titrate the sedation on top. Okay. But it cannot be done every time.
Very clear. We're running to the end, but there's just one last issue because that came up quite often in the Q&A about antidotes. One question, does it enable you to discharge the patient quicker if you standard give an antidote like flumazenil after the procedure? So first question. And the second question then to you, Wolfgang, in that first scenario, would you have given an antidote to that patient?
I wouldn't. I think sometimes you need to use antidotes to reverse the situation and to be able to transfer the patient to a recovery area where there is no need for a sedationist to be continuously there and just monitoring by a PACU or a recovery nurse. But I don't think it enables you to discharge the patient sooner home, because most of the antidote drugs in most situations, they work not so long as does the initial sedative drug. So the sedative drug will reappear, and then suddenly you can get back into deep sedation and you need to do something else. So the normal monitoring until the sedative drug is out and until you have normal Aldrich scores, you still need to take that into consideration. So it will not allow you to discharge the patient sooner.
So, yeah,
very quick answer. Very quick answer to the first sedation. Should I have used an antidote? I would say clearly no, I wouldn't, because I did not want to end the procedure. If I would have used antidotes, the procedure would clearly be ended. I would use the antidote only if I could not handle the situation with my normal measures, but I could do this. And so I would not use the antidote during the procedure. I can still think about using flumazenil after the procedure in order to antagonize a little bit the sedation, but probably not during.
Okay, that's very clear and practical. And I think that also answers one of the last questions. There was somebody asking, if I reach the CKIM and something like that happens to the patient and I'm there alone with the nurse in the room. That's the point you raised, Marc, about having somebody dedicated for the sedation there. And the question was, should I pull back and start the resuscitation? I think the answer is clearly yes. If you're in that situation, you cannot leave the colon inside. You have to cancel the procedure and restart maybe or reschedule. So, and I think that is something that you pointed out elegantly in your first talk, Marc, that having a dedicated person in the room can actually help you to avoid that particular situation where you can do what Wolfgang nicely illustrated in the simulation session. You just back the patient, you just ventilate and wait until that drop and respiration is overcome, and then you can actually continue the procedure. And as you said, Wolfgang, you don't have to finish the procedure and wake up the patient entirely with antidotes. So that's definitely an advantage. So I would like to thank Marc and Wolfgang for their excellent contributions, and also the audience for giving the nice interaction to through the Q&A. I think we learned a lot this evening about safe sedation, that risk assessment of the patient, like Professor van der Velde indicated, is the key issue for safe sedation. Try not to use too many combinations of drugs if not necessary. And if you do so, make sure you monitor the patient sufficiently so you can identify respiratory distress or stop a respiratory arrest before you have a drop in oxygenation. Also, to have a dedicated person in the room to take care of the sedation is something that actually should be pursued. We know this is not reality in many centers, but I think it's something you can address with your hospital administration. And then last but not least, and this is also something that came up very often about nurse-administered propofol sedation. This is definitely something that can be pursued depending on the legal situation in the country, and provided obviously that these people are very well trained at advanced life support. So thank you for joining this webinar. I would like to draw your attention also to the new benefits for ESGE members. So if you're not a member yet, please consider taking a membership. It's really not expensive, and you can benefit from many features like you can see here. You have the ESGE tutor, which is very new, where you can have tutorships for training and barretts and so on. We're continuously developing e-learning here, and you can also check your quality with the newly developed ESGE Quality Check app. And there's many more to find out on the website. And obviously, you can also participate in the ESGE webinars, which in the future will be also CME credited. And one of them is coming up on Wednesday, May 26th on third space endoscopy with Horst Neuhaus, Prof, and myself, Tantu. So thank you for joining this evening. Thank you again to the speakers, and hope to be seeing you soon in real life after the COVID crisis. Take care.